Dr. Nordella.
Yes, sir.
I was uh, I was not expecting Dr. Simon to be quite as amenable, but uh, but you're absolutely right. He didn't present the details, and and I have to say what he does present does ask a lot of questions. There are a lot more questions that need to be asked.
Agreed.
I don't know how many people will jump into this meeting, but unfortunately, I thought the other meeting would go longer. That's why I put 7:15. So I don't know if people are going to be waiting.
That's okay. Give it a few more.
Yeah,
Let's give it to 7. What do you say?
yeah. We should give it till 7 before we assume no one else is coming.
Hey, Brian,
Yes.
it certainly seemed like you were uninitiated and just looking for the first time, which it just seems like he downplayed everything.
Well, I was kind of surprised that he didn't downplay everything. Uh, I thought he would do more. I thought the whole presentation would have been much less candid, but um, but he certainly did not leave. He didn't assume anything to be critical. He just left the door open a little crack, and I think I appreciate that. I have to be honest. My knowledge of this area is from the standpoint of I think I know rather than I know, and so I have to listen very carefully and be careful not to make too many assumptions. But uh, but I do see holes in what's being presented, and I think it's the time it took to get this information. I think he sugarcoated that, but I can honestly say that with the information he presented and the questions that now come up from that information, it's going to take some time to get through it, and I'm not sure that we're going to get all the information necessary to do a really good analysis of it because there is a lot more information that needs to be compared. Would you agree, Dr. Nordella?
Yeah, and I think that he made a lot of comments we'll go through, but when he talked about the lab, it's a larger lab, and that is correct. We do have another lab. We could use LabCorp if they would come to the table, and we are not going to get that information. That is just not going to happen to the public unless we attempted to file some form of public records request that. Um, and I don't know if that will supersede the license or not. But that's why I had suggested at the last, turn it over to Sue. Let her do it. Sue
Yeah.
is a statistician, by the way. She's a PhD, and yes, she's an epidemiologist, but she's both. And my understanding was there's no statistical evaluation, and he talks about this confidentiality index. And yes, that's computed. It's 2 standard deviation off the mean, blah 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 blah. The issue is it's always presented with p-values in papers because it's just a simple way to say, look, I'm confident at a 95% level that this is accurate, and here's why. The p-value goes next to that. So anyways, and it's usually between numbers. So is it super accurate? No, p-values are much more accurate. And again, I don't see any, but we can start anytime you wish, or you want to wait a couple more minutes?
Well, it looks like we've got. Yeah, probably should wait till 7.
Um, can you hear me?
Yeah,
This is Mary.
absolutely.
Okay, sorry. I'm in my car actually. I had to pull over. The I think that the what he said about the cancer study very much misrepresents why, as CAG, why we disagreed with it. And I think it needs to be very carefully stated that we disagreed with it because the population comparison that USC had to do, they were very restricted by those, those sort of boundary guidelines and their own, guidelines and restrictions. So we basically said it dilutes the issue of comparing the Porter Ranch population or, other areas in North Valley, Granada Hills, Chatsworth, with other, groups that have been, had oil and gas exposure, et cetera. And even, at one of our subcommittee meetings, even the people at USC said that they couldn't do the kind of study that we wanted. They agreed that what we were asking for was a reasonable kind of study, but according to their own restrictive guidelines and sort of grant funding, they couldn't do it that way. And, I think that, what Dr. Simon was saying was, I think he threw CAG under the bus about that. Basically, USC, they do these really great studies. I don't disagree with that, but this was a very specific kind of question that we asked them, and they could not deliver on it, and they even admitted to that. And so to label CAG as being he didn't really say difficult, but he kind of inferred that is very much not the case.
I think to a point, Mary, you're right, but I think the problem really stems from the fact that there is a cost to doing this, and that cost is an impediment at the moment. And I think that's more of where they're coming from than anything else. And I don't think they're intentionally not wanting to find something. At least I hope not.
Right.
And I don't know that to be true. And I don't think that Paul was trying to ridicule the CAG. I just think that the difficulties that they're facing are causing them to not be completely candid. I could be
Right.
wrong, but I truly think that's the case. Paul has not been a voice of deceit, as I would say to some others, but I'm sure that I'm sure he's working for his paycheck too.
No, I would agree with you, Brian. I think that my impression of Dr. Simon is that he's part of a bureaucracy that wouldn't want to ask all the difficult, necessary questions. And if he was free to probably do a study or to listen like we would like him to, and I don't mean this in a disrespectful way. I think when you're stuck in a bureaucracy like DPH, your hands are tied in so many ways. And so, I think he tried. I think he got frustrated when he wasn't able to, assist us in lots of ways. And I think that the bureaucracy is tying everybody's hands, and that is that's going to be shameful as far as really finding the right answers.
Yeah. Okay, Dr. Nordella, we're past 7:00. We probably should move on.
So the first thing I want to say for people who think that I have a vendetta against Department of Public Health, I do not. Okay, I started this in a very benign position as medical director of that clinic. When I got the letters I got and the visits I got from DPH, did it make me upset? You bet it did, because it's something that needed to be investigated. And it's the people of the community that really paid the price. But yes, I have a personal problem with accountability. I try to, people can make me accountable, and right here and right now, you guys can ask any question at any time without any censorship. And if I can answer it, I will. And if I can't, I'll let you know. So I don't know if you want to start with the cancer first, but let's start with the CBC, since he did the same. The reason I did the CBC is because we had no biomarkers. There were no biomarkers I could go to and say, oh, look, your benzene oxide level is, 42, and that's elevated and blah, blah, blah. So I had to look at the end organs. So I went and looked at the literature. And those 2 articles are the articles I gave to Paul. Okay? And I just want to tell you the entire history so you understand this. And when I gave those articles to him and then presented the data, and it wasn't my study. This is a study that I modeled after the Texas City, Texas study, because it was quite concerning, because the children's had changes in one cell line. The cell lines have to do with the white cells, the neutrophils, the hemoglobin, hematocrit, the platelets, all of those. There are all kinds of cell lines that come out of your bone marrow from one cell. So the theory, as DeAndre put down, is that these chemicals are toxic and they suppress it. So you're going to see low numbers, and he's correct on one, is that in the children we thought what they call thrombocytosis, and in the adults we thought thrombocytopenia, which is low counts and elevated counts. And no one ever that I know, unless they totally misinterpreted, that did we say that there was a below normal or above the highest abnormalities. To look at that and say, your white count isn't, if it's 12,000, it's not 15, 17,000, or below, if it was 2.4, it wasn't below whatever that number was on the low. This was just looking at a community and looking at the bone marrow health of production. So we looked at those 3 communities, we put them together, and I put those 3 communities together because it actually accounted for elevation, okay? It wasn't a socioeconomic, it wasn't a race or gender issue or any of that, but we did go on because Sue, which is the statistician I turned all of this over to, she actually caught that and said, we should look at some other communities. And I said, great, what are you thinking? And so we went in, we found these, and we did comparisons to try and make it as apples to apples as we possibly could. So when I turned all of this over to him, I said, I'm quite concerned. This was December of 2019. Craig was at that meeting. We went to breakfast in the Valley, and he got everything. I reached out to Sue and said, would you mind if he called you on the phone? And she said, no. They called. He told me in a conversation she was quite qualified, okay? And they looked at the numbers and so forth, and he was quite concerned, and that's what pushed him forward. But it took them forever to get that data from Quest. And I don't know why. It took us 2 weeks to get it from Primex. And it's all computerized. And it took Sue about 3 weeks to do the analysis. I think that's very important. And back to the statistical analysis, what concerns me is the granularity of what they looked at. It also concerns me, and I'm sure it was a slip up when he said he had to either manipulate, I don't know what the word he was. It's like when they got the data, they had to go through it themselves and look at it. And that's why I wonder if the plaintiff counsel has the same data. Now, I haven't heard anything from an evaluation by plaintiff counsels in regards to the CBC study. But what we recently did with the HERE centers, we turned it over to their statistician and said, take a look, see what you find. If you don't find anything, wouldn't the community like to know that? So it's like, okay. So they took a look and they found significant p-values in different cell lines as composed to exposed people and unexposed patients. So that's a concern. Is then he looks at the time frame, and if you look at our graphs, they're quite a bit different, and there are significant differences in some of his data. I'm not sure, exactly which one he used as far as his comparison groups and so forth. I was trying to follow him really quick, but again, you have to have a p-value. When he talked about, oh, there was nothing there that signaled us. Okay, that's why I wanted him to come tonight. It's like, Paul, what do you mean by that? Because the only thing you could tell by what he has done is to say, okay, well, signal you, yes. So they're low, they're high, they're abnormally high. And I didn't catch the thing, but I'd be very interesting to follow up on it. When he talked about white blood cell counts being 50,000, that's leukemia until proven otherwise. Okay. So I didn't get that whole thing or what his explanation was. I wanted to, but it's very frustrating because you only have 90 seconds and it's really not a conversation. It's just, you ask that, they tell you whatever. And again, you get the whole issue of, we're going to continue to work with this. Okay, well, yes, we have COVID, I understand, but I'm sure you could put one person on it and finalize this out. And again, he said something that was very disturbing to me. He said, we're going to look at the LFTs, but I'm quite concerned there might be more significant differences. Well, if that is the case, why aren't we all over that? And I think, correct me if I'm wrong, and anybody can jump in, please, is that was the pediatric population. Am I correct on that, or did I hear that wrong?
No, I think you're correct.
Okay, so you have children out there, and again, remember, these toxins, probably, if I had to guess, very few of them go out of the urine directly. Some do, but I would say 95% have to be metabolized by the liver. And that's why you get chemical hepatitis. Hepatitis just means is that you have inflammation of the hepatocyte, the cell ruptures, it dumps those enzymes, intracellular enzymes, into the blood. The SGOT, the SGPT, the ALK phos, all of these different enzymes can then elevate in your blood, and you stick a needle, you draw it, and the LFTs are elevated. So if there's a significant difference in the LFTs, that tells me, that concerns me as a treating physician, and it should. So let's stop it. I'll stop it there. You guys can ask whatever you want to ask, and if I can answer it, I definitely will be happy to.
Mary?
No, do you think, Dr. Nordella, we should take Dr. Simon's, invitation at the end of the meeting? I think he said he'd be happy to, we could set up a meeting with him where he could go over the slides more specifically, and then we could ask those specific questions that you bring up.
Sure.
Because I think that it would be a gesture of goodwill on our part, I think, to say, look, we all want to be on the same page as far as clarification of this data and what it might mean and what it doesn't mean, and everything, because we just want a health study. That's all. It's been a very simple agenda and goal from the beginning, and if he's willing to do that, I think that would be very helpful. So maybe as CAG, we should request that.
I can honestly say that I will be talking with Andrew and Craig on this in regards to it, in regards to EHR as well. And right. I believe strongly that the only person on this meeting is Dr. Nordella that truly understands what was presented. And right. And I, for one, would like to understand a lot more of it. I see more questions. I have more questions now than before the presentation, and I can see where there are concerns I have with regards to the completeness of the information, and I want to understand it better, and I would like to look into it further. And although I can see that it's going to take some time and resources in order to do that.
Dr. Nordella, isn't it, the slides that he presented didn't really show, what's called the P factors. And isn't that the one that we're very concerned about? And there's not really any, they're not showing any data on that.
Correct. And now he said, and I listened to him when he mentioned P, my ears went up with the P value. It's like, well, we can calculate those. It was like, okay, so you haven't calculated them is what I would walk away from. And you can't look at a graph and say, oh, look at the difference here. Is that significant or not? That's not a scientific thought process. That does not work. You have to do calculations to see if they're different. And then he made the point and he said sometimes they're significant in regards to number, but not biologically. It's like, wow.
Yeah,
That
I heard,
kind of amazed me.
Doctor, I heard that too, and I wanted to question that. What in the world was he meaning by that? But I have to agree, he did state that p-values could be provided, but I'm not comfortable with them providing them. I would like to see the data that develops them.
You guys had met Sue Engels, and
Yes.
I just met her, but I interviewed her and we talked. And she, no offense, but SC UCLA, and she was schooled at UCLA, and now she's working with SC. So she is very qualified. I mean, I sat there and say, wait a minute, let me get my notepad because you're teaching me. So very, very qualified to look at this data and did everything for free, by the way. So there was no issue of her wanting to please us or do this. She just said, quote unquote, I love data. Now I did, and for full disclosure, I still owe her a Pete's coffee card, just to let you know, because she likes caffeine. And I will tell you this is that, there's nothing more exciting than seeing a statistician on caffeine. Okay. Stay cranked. So one thing that I do want to get across, and this is very, very important, is that, and this has been, I've discussed this with pathologists and so forth and so on. It's called dysplasia. And dysplasia just means that there is a change in a cell line. So to give an example, I think is very important. So when we all go at 50 or whenever you want to go, if you have positive family history, blah, 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 you go and have a colonoscopy. And they do a colonoscopy and they find a polyp. And they cut the polyp out, or they look at a suspicion lesion in the mucosa and they say, okay, let's excise that. Send it to the lab. You will have the pathologist look at that tissue under a microscope. And they can see changes in the morphology of the cell. And they call that dysplasia. When you cut out the dysplastic area, that doesn't go on into cancer, because cancer doesn't just go from a normal cell to an abnormal cancerous cell. It goes through changes. And some of those changes are not only the morphology or the structure of the cell, it's the number of the cells. And it was quoted by this old pathologist I interfaced with down at CAG. And he said, if you have dysplasia in one area of the body, you have it in other areas. And it was like, really? So we talked about that for a long time. So what you're seeing is that if there is a significant difference between the populations, and again, Andre only found one cell line and he produced a paper. Porter Ranch had 6 cell lines with the data that I had, according to Sue. So 6 cell lines were different than the control groups. Okay, so that really kind of frightened me. So that's why I wanted to go to Quest to get a bigger database, and they wouldn't turn it over to me. because I wasn't working with the Department of Public Health. So the whole principle of dysplasia is something you need to understand. Now, if you pull these chemicals back, all of the readings I've done, the bone marrow will heal itself. And that's probably why you're seeing some of the ups and downs. And I don't know if it's related to fugitive admissions or not. I just don't know. But you have to look at the fact that our database has significant, statistically significant difference in cell lines as compared to control groups. And I think that's important.
Doctor, when you speak of dysplasia and morphology, is it semantics for the layman to use the term mutation? Is that the same thing, or is that something different?
In essence, it could be. Yeah, absolutely. It could be a mutation that is causing dysplasia.
Okay. Anybody else have questions? Concerns?
I'd like to
Ideas?
suggest, I have an idea that we suggest a follow-up meeting. You talked about, having a more in-depth meeting with Dr. Simon, but I think a follow-up meeting would be good because there were a lot of things that he said we're still working on. So it would be really great to have a follow-up, and then any questions that Dr. Nordella has, he could, list them and ask them to be clarified for the follow-up meeting.
Agreed, Melissa, and we certainly will move on that as rapidly as we can, because he offers, we're going to accept.
Yeah, right.
First thing I would do, I think it's a great idea, but the first thing I would do is I would let him give Sue the data that he got from Quest and say, do the same analysis. And let's see what we come out with.
Yeah, I know, Doc. I know that's one of the things that we're all united on. I was talking with Craig about it as well. I know Andrew would feel the same way, and I think most of the CAG would feel the same way. It is much better to have multiple analysis than a single analysis. And since there has been so much difficulty, I won't say it any stronger than that, but so much difficulty with getting information out of DPH, I think we would all feel better if there was more analysis of an independent means. But I'm only speaking for myself.
How would we pay Sue for that? Because that's a lot more work than she did the first time around that she did for nothing, for a card that she didn't get.
I agree, Melissa, and I think that is something that we're going to have to wrestle with from the standpoint of EHR. And, I'm not sure how quickly we can move on it, but certainly it is something we need to consider and consider strongly.
I would highly suggest that you ask for a little bit of the 25 million. She's not that expensive. And yes, you're correct. It's probably a little bit more, but pay her something out of that. I want to say, and I don't know if I'm right or wrong, haven't they spent 2 million already?
Yes, they have, but according to Dr. Davis, it was 1.3.
Okay.
Yeah,
so,
they got some interest to offset.
I'm glad Dr. Davis wasn't there. I would have hit him with it. Okay, Mary, is your hand up again, or?
No, I'm sorry. I didn't.
That's
take
okay.
it
So I'd like to
I'm on a.
with the cancer, real quick. Then we can call it if you guys are fine.
I see Becky is here, and I see Assad is here. Any
Great.
questions from either of you? I know you haven't heard the whole thing. You came in a little late, but Dr. Nordella was doing a brief explanation of what he heard. Doc, if you'd like to summarize it a little bit for the newcomers, I appreciate it.
No, Brian, I heard it all. I joined you from 6 o'clock through the other meeting and this meeting, and it's excellent. Dr. Nordella, you brought us up to speed, and I appreciate it. And hopefully, as we progress, we get more of the people involved. I mean, what you said shouldn't have been just for 5-6 people on a handful. It should be on a town hall magnitude. And I appreciate all what you said the past hour. Thank you.
Okay, anything else, Doc?
Cancer.
Cancer, yes.
Okay, so I met with the same 2 cancer people before I ever got involved with the SOC, okay, or the CAG. You guys were not around then. And I talked to the exact same 2 people, and it was explained to me that when we looked at incidence of disease in a community, there was all inhibiting factors to it. They only do it one way, which was a concern to me, but they'll do it for you on a voluntary basis, so it doesn't cost you anything. So it's like, okay, so I have to come back with money, with a independent review board assessment, with all of these different things in order to look at a community. And by the way, this is very important. The study that he just explained and how what we did is we looked at zip codes and compared to zip codes, because you can go in to the zip codes and you can find a community that looks like yours on all of these issues, whether it be male, female, sex, gender, or race, ethnicity, age, on and on and on. And you can look at those and match your apples to apples. And then you just look at the incidence of disease in the community. Now, granted, there's some statistical hiccups to it, so you have to expand the study, and it just makes it a little bit more labor intensive. But don't forget that all of this is on computer. So it's like, I'm not sure, you know, the computers work very quickly. So it's like, why couldn't we do this? So they would, then I moved forward with the CAG. We got the subcommittee. We went back to the same people. Paul was there, others were there, and they went through it definitely more deeply. And it was like, okay, so hang on a minute. You can only use LA County as your control group. Brian, you brought the point up. You can't go anywhere without being exposed to this. And it's like, well, question after question, what's the accuracy going to be if your control group is contaminated? So if they're inhaling this and you're inhaling this, is that a true control group? And is that going to give you a significant incidence of disease? So, you know, you go back to it, and this is certainly not scientific, but you look at yourselves in your own testimony. And I can't tell you how many patients have told me their neighbor has this, that one has this one has this. What was very, very telltale to me is multiple myeloma. Multiple myeloma has a very small incidence of presentation. And I interviewed a patient that, and this is certainly anecdotal, that he said that he got his diagnosis, he was 52, he's out of the age group. He got his diagnosis the day that they buried his neighbor. The doctor called him on the phone after the funeral, and he died across the street of multiple myeloma. 1 month prior, their Little League coach died of multiple myeloma in that neighborhood. Now, it certainly is not scientific, but all I can tell you as a physician, I look at that and I go, wow, do you think we should be looking into this?
Dr. Nordella, it's
Yeah,
Lori.
please.
May I interject here from
Sure.
personal experience?
Sure.
Natalie's standing here with me too. Her third grade teacher, Sherry Weintraub, lives about 2 blocks from us. So she's about 1.8 miles from SS 25, but she also taught for many, many years at Castle Bay Elementary facing the mountain on the 2nd floor of the school. She contracted multiple myeloma and died less than a year after Mrs. Kimmel died from the bladder cancer that metastasized to her bones.
Yes.
But, okay, so that's one incident I know of. And now my sister-in-law, who lives within the 5-mile radius, they live near CSUN. They're just south of Nordhoff and off of White Oak. Yeah, she just had a stem cell transplant, 45 years old, multiple myeloma.
Right. And I've heard
That's too long for you.
And I've heard of other people call me when I was working at the office and telling me the same stories. And it was quite significant for me to sit there and say, wow, what is happening here? I mean, this is abnormal. I think if you look at it, it's anywhere between annually between 2 and 4 cases per 100,000 people. a year because I went in and you can go online. So when we went back and we said, well, you're not going to get an accurate study, are you? Because your control group is potentially contaminated. And it was like, yeah, well, that's the way we do it. It's like, okay. Can we do it another way? Yes, but it will cost you money. And Paul alluded to that, you know, it's more difficult. It's not more difficult. I think it's more labor intensive, which then costs the money, but it can be done. So if we want, I mean, you, the community, can go back and potentially demand that. But if they do this other study, I would say that it has a very low probability of showing anything. And then people are going to take that and say, I'm okay. And we brought that up to them. And I said, I think that's, and I told Paul in front of the researchers, and they all kind of agreed that that's kind of devious. I mean, we're not giving them any accuracy to this study. So why do we want to do that if it's going to be misread? It's just, again, to me, it's not appropriate. If you're going to do it, let's do it right. Let's put our heads together and do it correctly. So we're going to work with the HERE Center, which is the environmental people out of CSUN. And the first thing that I would highly suggest we do is we go back in and we survey the community. And you know, symptomatology, are you still sick? What did you have before? And the other thing is we can do our own cancer survey if people will release that. Now, what inhibited that before was the whole issue with the litigation. But I don't know where you guys are at with that. I've heard there's a potential settlement that's being run around or whatever. But that might be, if that resolves itself, we might have more of an open playing field to get this information out of the community, because it's always been a hiccup.
Any other thoughts? Anybody? I will tell you, Doc, that, or everyone, that 4 years ago, a friend of mine was diagnosed with multiple myeloma, and within 2 years he passed away also. And he had no, to the best of my knowledge, he had no medical history to speak of, but I could be wrong on that one.
Once the diagnosis is made, you have 18 to 24 months before death.
Well, that worked out here. And he lived in Northridge, just pretty much directly south of Porter Ranch. He lived down on Superior, west of Balboa. And it was a surprise to everyone when it happened, when he was diagnosed. And, you know, some would think he's out of the range, but based on the duration of this blowout and the wind patterns and directions, it makes sense. Can't say that it's the cause, but it does make sense.
So kind of in conclusion, everybody's probably watching the Dodger game, I know I am, is that I would highly suggest that CAG go back, have him, Dr. Simon, turn over that data set to Sue and let her do an analysis. Then I think, and she could be on the call or the town hall, is then let's go through it and see what they're finding and what she finds. That'll be interesting to see if that actually occurs. Okay. So, and yes, you could pay her a small stipend. I'm sure that they can afford it since we pay them 1.3 billion annually in tax dollars. And to me, it's a great return on your dollar. That's number one. Number two, I would say, really, unless you wanted to, I wouldn't have them do the cancer thing. I would say, wait, let's survey the community and then have a little data and some information saying, look, we've looked at this, we've done another survey like the Casper, and we came back and we said, we have X amount of cases of this, X amount of cases of that, on and on and on, and we might find nothing, and that would be fine. But if you did a survey, a neutral survey, if you find something, then you have some data to go back to them and say, well, look, we did a survey of the community and these people have been diagnosed. And by the way, just to let you know, the cancer program at CAG takes 2 years in the rears to get their paperwork for final diagnosis, final pathology, on and on and on, to actually enter things into their computer system. So it's backed up. So you're not going to see it's 2021, let's say it's 22. You're not going to see the stuff, you'll get the stuff from 2019, which might be fine. But just so you know that point. So that's what I would do. Let's get some more information that it's more difficult for them to turn away and not to do what they need to do.
I think we're all in agreement.
Yeah.
I can honestly say that the best of all worlds is we find absolutely nothing.
Great.
And so we'll be looking for the best of all worlds rather than the worst. So, any other questions? Yes, Becky.
Can you hear me? I just have a question.
Yes, we can.
Okay. I'm a baseball fan and I have a baseball family in professional sports. So I'm sorry that I tuned in a little bit late, but there was a reason. My husband, he on September 30th, walked out of Islands and got a case of hiccups that I really feel were more like seizures that lasted for 5 days before I took him to the emergency room and had it diagnosed, and he was in the hospital. He died 5 or 6 months later.
Sorry to hear that.
And I really do believe it had to do with the gas leak. And it's been a horrible 5 years having to deal with all of this. Other than cancer, are there other respiratory diseases that have been attributed to this gas leak? And I really, really would love to get a list of the chemicals that were released, being that I've lived here for 40 years. And we were not able to evacuate because my husband was so ill that we had to stay and take care of him in the hospital and here. And I was just kind of wondering if there were any other fatalities or deaths related to the gas leak that weren't related to cancer, like epiglottis issues, things like that, breathing issues.
Yeah. So Becky, I'm sorry for your loss.
Me too.
What was his final diagnosis? If you don't mind sharing. And
My
if you
final,
do-
well, he went into the hospital. He had surgery. He had like surgery. They could, they really didn't have a lot of information. On the death certificate, I think it lists a heart attack because, they take you off of everything and that's what happens.
Well,
but
everybody does that. They just say that death was caused by cardiopulmonary arrest.
Exactly. But he had, it was a epiglottis infection. He was in the hospital for 4 or 5 days. He had trouble. They had to give him injections to stop. I call them seizures. He had gone to, the facility, on, Corbin or on Rinaldi and twice, and got medication that didn't help, but he couldn't sleep. I finally, that happened on a Friday night. Finally, Tuesday night, I said, this is it. We're going to the hospital. We went to West Hills Hospital and he was there for a week. And it was an swollen epiglottis and tracheal infection. He was so healthy. I mean, he walked and the thing is, he spent a lot of time in Porter Ranch. He had an insurance company on Devonshire, and he'd come home. He'd walk up near the gas leak. He walked 5 miles a day every day. He was, very fit.
So I got a couple of questions for you. Did they call it that he had epiglottitis?
Yes.
Did they have to intubate him and then trach him?
I believe so, yes.
Okay, so he had a trach in his neck that he had to breathe through?
Yes.
Did they ever do an MRI?
Yes.
I mean, the nerves that innervate the hemidiaphragm that causes the spasms and the hiccups all run through there. So he could have had metastasis to a nerve or something like that triggered that. I don't know. Did they do a postmortem on him?
I'm not sure if they did or not.
Okay. Did the doctors all sign off on the death certificate? So they wouldn't have had to have done that if that was the case. Or sometimes the doctor feels uncomfortable and says, I really don't know what took this patient's life. So therefore, they'll release him to the morgue.
I'm not, you know what?
Okay.
This is my first time. I don't know Dr. Nordella. I
Yeah.
just know that he was everybody knew him as a very fit, healthy person. He got the hiccups, and that was the beginning of the end.
Yeah, and that could have been a mass up in his neck, which would have been interesting to have an MRI of the soft tissues of his neck.
And I will tell you, he had a lot of nosebleeds.
Yeah.
I had a total knee replacement 3 weeks ago, and I don't know why I'm missing my co-pilot so much, during all of this. But all of a sudden I started remembering all the nosebleeds that he had that were unexplainable. I mean, it's just unbelievable.
So back to your other question that you asked, respiratory disease, that's the first organ system that I would love to see them study if they were going to do a patient-centric study. And you would start very briefly by just doing a chest x-ray and then pulmonary function testing. And that's really easy. And don't forget, the upper airway from your nose on down is all part of your airway.
Right.
So when you ask is like, do you have disease? That could be. I worry about more so with patients is what it's caused deeper down into the lung tissue. So these toxins destroy tissue, and then it goes into the blood and gets transported throughout the body and can affect other organ systems. So it's a tough thing. So I hope I answered your question.
Thank you so much.
You're welcome.
Anything else?
Yeah.
Mary?
We're gonna follow up with a meeting with Dr. Simon.
Yes. We'll certainly bring it up, and hopefully the CAG will come up with a time to meet that we can all agree on. If the CAG can't do it, I'll also bring it up to EHR and see if EHR can make it happen. But one way or the other, I think since Dr. Simon offered, we need to follow up with that at some point, and sooner than later.
Could you please put a stipulation on that and have him send it out to Sue first? At least let him deny it.
Yes, Doc, I agree with you.
Okay.
Yeah, when Sue gets her eyes on it and she does a fantastic job, she can confirm and say, yeah, everything is normal here or whatever, or she might do more calculations and actually help them. I don't know.
Yep.
And Dr. Nordella will I'm concerned that DPH, they might have some reason why they wouldn't send it to her. He stated, Dr. Simon, in the meeting, their statistician, very competent, etc. So, we've hit those roadblocks before where no, we can't because of this reason or this bureaucratic reason or whatever. So then what?
Well, I think that the issue there is that he's already kind of forewarned you. He says, I have to take this by county council.
Okay.
And the issue there is that they could just say no behind closed doors, and he has to come back and say, well, our county council doesn't. And let me just tell you something. If she signs a contract, just as anybody would sign a contract for further evaluation, they have to abide by it. And so that shouldn't be a problem unless you just didn't want it out.
Right. Okay. I guess I don't know why they wouldn't want someone else's eyes on it. I just, I would think they would want to do that, meaning DPH, just for transparency with the community, but I'm not hopeful that they would. So
the thing I would be very, very, very interested in, I would like to see the data on the thumb drive from what they received and what they evaluated, okay, as compared to what the plaintiff counsels received. Is it the same data set?
What? Yeah, she said cool.
Okay.
All right. I think
Done.
we pretty much killed it unless somebody has some more questions or issues.
Dr. Nordella, thank you.
You're welcome.
You.
I
Thank
think
you.
did a great job, guys.
Yep.
I appreciate it.
Well, thank you
Dr.
everyone for
Nordella,
coming.
thank you for
Thank you,
your time,
Dr.
as always.
Laurie, did you have something?
Oh, I just want to thank Dr. Nordella for his time and his caring for our community, as always.
Indeed.
No problem. All
Thank
right,
you,
guys.
Doc. I appreciate your coming and sharing with us your feelings and thoughts and observations. And, everyone stay tuned because there will be more meetings.
Yeah.
All right, you guys have a good evening. Thank you.
All
Thank
right.
you, Dr.
Everyone.
Nordella.
Thanks, everybody.
Thanks.
Bye-bye.
Thanks for running the meeting, Brian.
Yeah,
Sure.
thank you,
No
Brian.
problem.
All right, everybody. Good night.
Good night. Go Dodgers.
Thank you, Brian. Thank you, everybody. Good to see
Bye-bye.
you. Bye.